بسم الله الرحمن الرحيم.
Good morning, doctors. I am Dr. Shafiqur Rahman, Chief and Founder in the Dr.M Education Valley. Today we are going to start other series of the lecture on the antibiotics. We will discuss today protein synthesis inhibitors. Para los estudiantes que hablan español, luego voy a dar unas lecturas sobre los antibióticos. To understand the protein synthesis inhibitors, first we need to understand how the proteins are synthesized. The synthesis of the proteins is called the translations. Let's start with the translation. Most of the genetic information stored in the genome codes for the amino acid sequence of the proteins. For these proteins to be expressed or text in nucleic acid language, therefore has to be translated into protein language. This is the origin of the use of the term translation to describe the protein biosynthesis. The dictionary used for the translation is the genetic code. So simply we can define the translation is the synthesis of the proteins in the ribosome by the polymerization of the amino acids utilizing the messenger RNA and the transfer RNA. To understand the pharmacology, it is necessary to know about the three main steps of the translation: initiation, elongation, and the termination. Prokaryotic cell translation is initiated by the formation of the initiation complex consisting of the 30S ribosomal subunits, formine methionine, transfer RNA, and the messenger RNA. The 50S ribosomal subunits then joins the complex. Protein called the initiation factors also involved but not shown here. The 70S ribosome has the two sites to which the transfer RNA carrying amino acids combine. The initiating transfer RNA carrying the formyl methionine binds to the P site. A transfer RNA then recognizes the next codon and carries the second amino acids, then move into the A site. The formyl methionine carried by the transfer RNA in the P site is then joined to the amino acids on a site just carried by a transfer RNA by a peptide bond. The ribosome now advances a distance of the one codon and the transfer RNA that carries the formyl methionine is released at the E site. A transfer RNA carrying the next amino acid now moves into the A site where the anticodon on the transfer RNA matches the codon on the messenger RNA. The ribosome shifts down by a distance of one codon As shift on two amino acids on the P site combines the second amino acids and the second transfer RNA is released from the E site. The ribosomes continue to move on the messenger RNA and a new amino acids are added to the growing polypeptide chain. Elongation of the polypeptide chain is terminated when a stop codon move on the A site. Stop codon doesn't specify the amino acids and doesn't have a corresponding transfer RNA. The ribosome dissociate into its 30s and 50s subunits and the messenger RNA and the protein are released. Today our topic is protein synthesis inhibitors, the major group tetracyclines, which consist of the four fused cyclohexane ring with the system of the conjugated double bonds. Simply we define the tetracycline as a bacteriostatics and the broad spectrum antibiotics that kills the certain microorganisms which causes the infections, and these drugs are used to treat a variety of the infections. In late 40s, as usual, it was now era in search of the bacteriostatics. The development of the tetracyclines antibiotics was the result of a systemic screening of the soil specimens collected from the many parts of the world for the antibiotic producing microorganisms. Chlortetracycline is a prototype drug of this group, which was introduced in 1945, followed by the oxytetracyclines and the tetracyclines in 1950 and the 1952 respectively. To understand the tetracycline, we classify the tetracyclines in two major groups: naturally occurring tetracyclines and the semi-synthetic tetracyclines. In the naturally occurring tetracyclines include the oxytetracycline, demaclocyclines and the chlortetracyclines. Tetracycline itself included in the naturally occurring tetracyclines. Semi-synthetic tetracyclines include the minocycline, doxycycline, metacycline, limecycline, maclocyclines and the Rowley tetracyclines. We can classify the drug members on the basis of the half-life. Depending upon the half-life, short-acting tetracyclines, intermediate-acting tetracyclines, and the long-acting tetracyclines. Tetracycline are a group of the closely related compounds that, as its name indicates, that consist of the four fused cyclohexane rings with a system of the conjugated double bonds. Substitutions on these rings are responsible for the variation in the drug's individual pharmacokinetics, which cause the small differences in their clinical efficiency. Free tetracyclines are crystalline amphoteric substances of the low solubility. They are available as the hydrochlorides, which are more soluble. A newly approved tetracycline analog, tetracycline, is the glycyl cycline and the semi-synthetic derivative of the minocycline. We will see what is the source and the chemistry of the major tetracyclines. Oxytetracycline, a natural product isolated from the Streptomyces rhamnosus. Tetracycline is a semi-synthetic derivative of the chlortetracycline, which is isolated from the Streptomyces aerophaciens. Others, doxycycline and the minocyclines, are the conjugate of the tetracyclines. Now we will understand how the tetracycline works. Entry of these agents into the susceptible organisms is mediated both by the passive diffusion and by an energy-dependent transport protein mechanism, which are unique to the bacterial inner cytoplasmic membrane. The drug binds reversibly to the 30S subunit of the bacterial ribosome, therefore blocking the access of the amino acid transfer RNA to the messenger RNA ribosome complex at the acceptor site. By this mechanism, bacterial protein synthesis is inhibited. Tetracycline binds to the 30S ribosomal subunits, thus preventing the binding of the amino acid transfer RNA to the ribosome. Tetracyclines are the broad-spectrum bacteriostatic antibiotics that inhibit the protein synthesis. They are active against the many gram-positive and gram-negative bacteria, including the anaerobes, Rickettsia, Chlamydia, Mycoplasma, and the Legionella forms, and against some protozoa, for example, amoebae. Tetracycline have a broad spectrum of the antibiotic actions. Originally, they possessed some level of the bacteriostatic activity against almost all medically relevant aerobic and anaerobic bacteria, both gram-positive and gram-negative, with a few exceptions such as the Pseudomonas and the Proteus species. Tetracyclines remain especially useful in the management of the infections by the certain obligately intracellular bacterial pathogens such as Chlamydia, Mycoplasma, and the Rickettsia. They are also of the value in infections such as syphilis, leptospirosis, and the Lyme disease. Certain rare are the exotic infections including the anthrax, plague, and the brucella are also susceptible to the tetracyclines. Now we will see how the tetracyclines are absorbed, distributed, and metabolized in the body, and finally how they are excreted from the body. Oral absorption of the most tetracycline is incomplete and the percentage of the unabsorbed drug rises as the dose increases. Tetracycline absorption is impaired by the concrete ingestion of the dairy products, aluminium hydroxide gel, calcium, magnesium, iron, or the zinc salts. After a single oral dose, peak plasma concentrations of the oxytetracycline and tetracycline are attained in 2 to 4 hours. These drugs have a half-lives in the range of 6 to 12 hours and often are given 2 to 4 times daily. Tetracycline distribute widely throughout the body, including the urine and the prostate. They accumulate in the reticuloendothelial cells of the liver, spleen, and the bone marrow, and in bone itself, in the dentine and the enamel of the unruptured teeth. Tetracyclines cross the placenta and enter the fetal circulation and the amniotic fluid. Relatively high concentrations are found in the breast milk. Minocycline best cerebrospinal fluid penetration. Tetracyclines are primarily eliminated by the kidney, although they also are concentrated in the liver, excreted in the bile, and partially reabsorbed through the enterohepatic recirculation. Minocycline is significantly metabolized by the liver. That's why we can use in the renal insufficiency or a renal failure. A wide variety of the tetracyclines are available for the oral, parenteral, and the topical administration. Tetracycline in the adults for the oral users is 1 to 2 gram per day in the adults, and in the children 25 to 50 milligram per kg daily in the 2 to 4 times daily. Demeclocycline 150 milligram every 6 hours used rarely as antimicrobial agents because it causes the photosensitivity reactions and the nephrogenic diabetic insipidus. Doxycycline dosage for the adults is 100 mg per 12 hours on the first day, then 100 mg once a day. In the children, 4 to 5 mg per kg per day on the first day, then 2 to 2.5 mg per kg once a day. Dosage in the parenteral of doxycycline is 200 mg IV infusion on the first day, then 100 mg once or twice daily. Tetracycline in the acute infections is 1 gram, 2 gram in a severe infection, division in equal doses. Three mechanisms of resistance to the tetracycline are important. The first one is the impaired influx or the increased efflux by an active transport protein pump. The second one is the ribosome protection due to the production of the proteins that interfere with the tetracycline binding to the ribosomes. The third one is the enzymatic inactivation. The most important of these are the production of an efflux pump and the ribosomal protection. More significant plasmid encoded proteins responsible for the efflux of the drug pumped out. Plasmid encoded proteins that binds to the ribosome and blocks the binding site. Tetracyclines have been used extensively to treat the infectious diseases and food additives in the animals, leading to the widespread resistance. They remain useful for the infections caused by the Rickettsia, Mycoplasmas, and the Chlamydia. Doxycycline is used for the respiratory infections that increasingly are resistant to the other drugs. Tetracycline may be life-saving in the rickettsial infections, including the Rocky Mountain spotted fevers, epidemic typhus, scrub typhus, rickettsial pox, and acute fever. Improvement often is evident within the 24 hours. Doxycycline is the drug of the choice for the suspected or the proven Rocky Mountain spotted fevers in the adults and the children, including those less than 9 years of the age. In the home, the risk of the staining of the teeth is outweighed by the seriousness of the potentially fatal infections. Mycoplasma pneumoniae is sensitive to the tetracyclines, which shorten the duration of the clinical manifestations in the atypical pneumonia. Pneumonia bronchitis are the sinusitis caused by the chlamydia pneumoniae response to the tetracycline therapy. The tetracyclines are also of the value in the psittacosis. Doxycycline 300 mg as a single dose is very effective in reducing the stool volume and eradicating the Vibrio cholerae from the stool within the 48 hours. Antimicrobial agents are not substitute for fluid and the electrolyte replacement in this disease, and some strains of the Vibrio cholerae are resistant to the tetracycline. Tetracycline have been used to treat the acne by inhibiting the propionibacteria which reside in the sebaceous follicles. Generally, to treat the acne, low doses are used, 250 mg oral twice a day. Doxycycline 100 mg twice a day up to 21 days is the first line therapy for the lymph granuloma venereum, which is caused by the chlamydia. Trachoma is very important in the early childhood before the complete calcification of the permanent teeth, and the tetracyclines therefore often are contraindicated. Doxycycline 100 mg twice a day up to 14 days are the tetracycline 250 mg 4 times daily up to the 14 days is very effective for the treatment of the trachoma.